Good evening, aspirants. We shall begin the class now. So, the topic for today is gastroenterological emergencies and surgeries. And the speaker we have here is Dr. Deepak Gupta, who is a locum consultant in ICU at Wolford General Hospital, North London. Thank you, sir. So, you may begin.
So, good evening, everybody. Uh, Today's topic is for gastrointestinal emergencies and surgery. There are two types of questions in the EDIC exam, as you all must be knowing. It's type A and type K. The type A questions are the one questions with which have 5 answers, and you have to choose the correct answer. While type K are the type of questions in which they have 4 answers and you have to answer as true and false. Okay. I'll be taking the type A questions first and then the type K. The ratio of questions in the EDIC 1 exam, it's not always fixed. Sometimes 60-40, 70-30 or 75-25. Such questions come in the EDIC 1 exam depending upon. Okay. So the first question for you all is, this is the type A question. A 55-year-old man with a history of hepatitis C, alcoholic cirrhosis, admitted to the ICU from ED with suspected upper GI bleed. He has a history of esophageal varices requiring banding in the last year. He started on PPIs and octreotide in the ED, and gastroenterology was consulted. Soon after the arrival to the ICU, he decompensates with copious hematemesis and becomes hypotensive. The upper endoscopy for the source of control is not available for at least an hour. In addition to the continued resuscitation while awaiting gastroenterology, which of the following is the most appropriate management for this patient? The 4 options for this are: place a nasogastric tube, start antibiotics for SBP prophylaxis, and start a low dose beta blocker to decrease portal venous pressure. Second is to intubate the patient for the airway protection and place a Blackmore tube for hemorrhage control. Third is to place a Blackmore tube for hemorrhage control and start antibiotics for prophylaxis. Last one is to intubate for airway protection, place a Blackmore tube for hemorrhage control and start antibiotics for SBP prophylaxis. So, what do you feel is the correct answer out of this? You can answer in the chat box and then we'll discuss what exactly is the correct answer. D, someone has answered. D, anyone else want to attempt? See, what I want to say is, this is not an actual exam, this is just a practice session. You should try to answer whatever you feel is correct. Even if it's wrong, there is nothing will happen. You learn from these mistakes and you will not make the same mistakes in your actual exam. Okay. B, someone has answered. No problem. Whatever you feel, you can answer, and then we'll discuss exactly what is the answer of this. Okay. So for this question, the correct answer is D. Most of you answered that correctly. It is, first you will have to intubate the patient, place a Blackmore tube for hemorrhage control, and start antibiotics for SBP prophylaxis. So why this answer is correct? See, cirrhotic patients with esophageal varices can decompensate very quickly and require skilled resuscitation to maximize the chances of survival. This patient has sentinel bleed before ICU arrival and was started on appropriate therapy in the ED. On arrival to the ICU, the condition worsened with significant upper gastrointestinal bleeding. Airway management is very critical. Okay. So the intubation is necessary for any gastrointestinal procedure as in placing a Blackmore tube. So The Sangestan Blackmore tube is just a rescue measure, and it can be done uh, only after intubating the patient. You cannot just put this tube without intubating. So the first the intubation to be made, and then Blackmore tube in the esophagus is to be inserted. Often overlooked for critical to improved outcomes in is antibiotic prophylaxis to prevent the SBP in cirrhotic patients with varicose hemorrhages. Starting a third generation IV cephalosporin has been shown to reduce all cause mortality, infection related mortality, rebleeding events, and hospitalization lengths of stay. So the third most important part of this question was the antibiotic, which has to be started even if you don't suspect an infection, because there may be an infection and it may be an SBP. Okay. Inserting a nasogastric tube is not incorrect because it has never been shown to worsen the varicose bleeding, but starting a beta blocker in this acute setting in hypotension is incorrect because it may worsen hemodynamics. So the best option and the best answer was D for this question. We'll move on to the next. Just wanted to share one article with you. It is a practice guidelines for the diagnosis and treatment of alcoholic liver diseases 2019 by the American Association for the Study of Liver Diseases. You can find this on net. If you would read, it's a very nice guidelines given for this. Okay. Second question. This is a 38-year-old woman at 34 weeks gestation admitted to the ICU with altered mental status and jaundice. Right upper quadrant ultrasound reveals a fatty liver. Which of the following is the most appropriate therapeutic intervention? You can answer in the chat box. If you know what the problem this patient is facing, you will be able to answer it. Pregnancy with mental status, altered mental status, jaundice, and right upper quadrant pain. Anyone? Yeah, yeah. Correct. Yeah, most of you got this correct. The option D is correct. That is the delivery of the fetus. Let's see why this option is correct. So, exact diagnosis in this case is acute fatty liver of pregnancy. It is a life-threatening condition occurring in the last trimester. Differentiation from the HELP syndrome and severe preeclampsia may require a liver biopsy, but acute fatty liver of pregnancy is associated with hepatic dysfunction, including the synthetic function. Ammonia and transaminases levels are higher. Hypoglycemia is more frequent and disseminated intravascular coagulation is common. The treatment of choice for this is delivery of the fetus and supportive care. So this was the correct answer. It's a 34 weeks gestation. You have to do the delivery of the fetus in this case. Okay. We'll move on to the next question. This is a 41-year-old female which presents with abdominal pain, nausea, vomiting, and diarrhea. Examination shows her to be mildly jaundiced in AF and agitated with bibasal crackles on chest auscultation and peripheral edema. Observation include heart rate 134, BP 76 by 45, respiratory rate 28, saturation 93% on room air, and temperature 39.6. She has mildly deranged liver function tests, a normal white cell count, CRP. A beta HCG test suggests she is pregnant. What is the most likely diagnosis? Yeah, can you answer this? The options are thyroid storm, decompensated alcoholic liver disease, sepsis, malaria, ectopic pregnancy. Very clear cut clues given in the question. If you catch those clues, you can get the answer in this. Second question again on pregnancy. Anyone wants, they can answer in the chat box. See, even if it's wrong, don't worry about this. You should at least attempt. Okay, see, someone has answered E, someone has answered D. Okay, let's see what the correct answer is. The correct answer for this question is A. It is what is? It is a thyroid storm. It is very common in pregnancy, and many clues were given: high temperature, tachycardia, hypotension, high respiratory rate. We'll see what is it. See, the combination of symptoms seen in this patient is highly suggestive of thyroid storm. Pyrexia is not generally a feature of decompensated alcoholic liver disease, and sepsis is unlikely given the normal WBC and inflammatory markers. Patient with malaria usually presents with fever, headache, malaise, and gastrointestinal jaundice, and respiratory symptoms can be seen. However, tachyarrhythmias and cardiac failures are not normally present. So the other things are ruled out, and the most probable diagnosis in this case is thyroid storm. So thyroid storm, it is explained everything over here. It is difficult for me to complete the 25 MCQs and explain each and everything. So I think thyroid storm, you can read from most of the textbooks or the explanation given over here afterwards. I'll not go into the detail of it, or will not be able to complete even 10 or 15 MCQs within an hour. Okay, so you just read it, but this type of questions will come in the exam. We'll move on to the next question. You are asked to admit a 48-year-old female with acute on chronic liver disease and grade 3 encephalopathy. She has been admitted under the medical team with acute kidney injury and deteriorating liver function tests. There is no clear precipitant for the decompensation of history from the family. They also state that she continues to drink heavily. On review, she has a normal oxygen saturation on FiO2 of 0.4 with a PO2 of 10 kilopascals. She is hypotensive 76 by 40 and tachycardic 110 beats per minute. The catheter in situ, and she has passed 20 mLs of urine over the last 8 hours. Her bilirubin is to 30 millimoles per liter and alanine transaminase is 56, creatinine is 478. Which of the following prognostic systems is likely to be the best predictor of outcome in this patient? So the options are MELD score, Child-Pugh score, Apache 2 score, SOFA score, or Glasgow Coma score. Now, see few important tips regarding solving questions in EDIC 1. Okay, someone has answered. I think A, someone has answered MELD score. Okay, MELD score. Okay, okay. Few general tips regarding solving questions in EDIC 1 exam. The first thing what I wanted to tell you is, could you see how I was reading the question? So in most of the questions, the EDIC 1, they give a very big story. It's a very long question. You have to have the practice from today itself. You try to read the question very quickly, because if you go on reading very slowly, like you are asked to admit 48-year-old female patient acute on, it will waste your time. Most of the things are big questions are given to just waste your time so that you are unable to complete the paper. You have to make a practice to read the questions clear, fast, and just grab the important points which are there. Other thing is like what I read on review, she has a normal oxygen saturation FiO 2.4, hypotensive. Just don't read she is hypotensive. Just BP you can see, heart rate you can see, and oxygenation you can see. So make a habit of reading fast the questions so that you can save time and you can complete the paper. Stories are given just to waste your time. Okay, so in this question, the could and the most important of the whole story is the last line. What is the last line? Which of the following prognostic systems is likely to be best predictor of outcome of this patient? So it is not asking you about the liver. They are asking how would you prognosticate the patient. It's about prognostication. The word prognostication is very important. Exactly. Few of them have got this correctly now. MELD score, Child-Pugh score, they will tell us about the present liver condition. But the correct answer for this D, it is the SOFA score. Why? It will help you with the prognostication. Okay. Sorry, anyone has to say something? Okay, okay. Maybe by mistake the mic was turned on. No problem with that. Okay, so the correct answer is D. It's the SOFA score. Why we'll see this answer is correct? So this patient unfortunately appears to have a multiple organ dysfunction. There is neurological, hepatological, cardiovascular, or renal involvement. Prognosis in this situation, especially in the absence of reversible precipitant, would be very bleak. Recent data would suggest the following: three organ failures and mortality about 90 to 100%. Interestingly enough, the generic organ failure scores appears to perform better on predicting outcome than specific liver disease scoring systems. Are you able to understand what exactly they were trying to ask? They are not asking only specifically about the liver disease scoring system. It's like a multiple organ dysfunction happened over and four of the organs are involved. At the recent systematic review, the SOFA score performed best with an area under the receiver operating curve. AUC is more than 0.9 with reporting excellent discrimination. In contrast, child score demonstrate AUC of 0.6, 0.7 and MELD score around 0.8. As such, if you were seeking to discriminate likely survival, the SOFA score would be the best choice to guide the clinical decision making in an acute situation. So the SOFA score was the correct answer. Okay, let's move forward. Let's see the next question. Now, this is a 71-year-old woman admitted in the hospital with diarrhea, having discharged from hospital 15 days prior following treatment with metronidazole for C. difficile. Past medical history includes hypertension, IHD, diabetes. She also had CD at 3 months previously, treated with metronidazole. She is having 5 to 7 stools per day, which is positive for C. difficile infection. Investigation showed heart rate 95, BP 108 by 76, 38 degrees centigrade, creatinine 94, WBC 12 in 12,000, most appropriate therapies. Oral metronidazole, vancomycin, fecal transplantation, fidaxomicin, oral rifampicin 300 milligram. So, few tips regarding this question. First thing is C. difficile, one of the very favorite topics of EDIC 1 examiners. Mostly out of 100, one or two questions definitely you will get on C. difficile infection. It's one of the favorite topics of EDIC examiners. So they put a question on this. And you should be very thorough regarding the treatment of C. difficile, regarding which is the treatment in the first case, which is the treatment in recurrent cases, and which is the treatment in refractory cases. What are the last resort for C. difficile? Okay, not very common in India. We don't treat so much, so we don't have much knowledge. But theoretically, you should be very clear regarding this, because here in UK, it's very common, and every diarrhea patient in our ICU, what we get, has to be investigated for C. difficile infection. Okay, so very important topic. You should be thorough. Okay, someone has answered correctly. Yes, I think most of you have got this correctly. Its answer is D, that is the oral fidaxomicin. It's 200 milligram BD is the dose. So answer is D. This patient has got recurrent CDI, because see, there was given it was previous also. Therefore, this current infection should be treated with fidaxomicin to decrease the risk of further recurrences. Severe cases not responding to oral vancomycin should be treated with high dose oral vancomycins and IV metronidazole. Oral rifampicin and intravenous immunoglobulins can be used, but there is no evidence to support the use of this agent. Fidaxomicin, regarding it, its complete explanation is given. You can read it anywhere in the books, it is given. And last resort is fecal transplantation. Rarely has adverse effects and causes resolution in 81% of the patients. Okay, so you go home and read this topic C. difficile. One thing I just wanted to say is new guidelines of C. difficile has come up in the recent years. The old guidelines have been changed. So the EDIC 1 people focus whether you know the newer guidelines or not. So this is just a screenshot I have taken from the newer guidelines. On the net you go, you will get the recent treatment of C. difficile infection, and just read it and be thorough with it. Okay. You can read, this is a 2021 guidelines given by IDSA, which are the which will explain very nicely the C. difficile infection. But the treatment which has changed recently, you need to go through the recent treatment last year which they have changed. Okay. Now, regarding penetrating abdominal injury, the following are true except the most common cause of death in the first 24 hours is hemorrhage. Peritonitis is in a hemodynamically stable patient is an indication for laparotomy. Most commonly injured organ in penetrating stab wounds is the liver. Chest X-ray is an insensitive test for diaphragmatic injury, and a negative fast scan has a high negative predictive value for injury requiring laparotomy. So another tip I want to give in this question is just read this regarding penetrating abdomen. The following are true except. Okay, they could have written in this the following statement is false, but usually this is a very common thing in EDIC exams. They write this true except. If you don't read the question carefully, that true except, if you find a true question and you mark and go ahead, it will be wrong. So concentrate too much on every word which is given in the question. Okay. So what is the correct answer? You can answer in the chat box. Which is the what they are asking is which is the false one out of the five? Which is the false statement regarding penetrating abdominal injury? Anyone would like to attempt this? Okay, I think yeah, few people have tried to attempt E. Okay. Let's see what the correct answer is. Okay. The correct answer is E. Both of you answered this correctly. So, a penetrating abdominal injury may cause injury to vascular structure, solid organs, or a hollow viscus. Peritonitis may reflect leakage of digestive tract contents from a hollow viscus and is an indication for laparotomy. Most commonly injured organs, the first one is 40% liver, small bowel 30, diaphragm 20, and colon 15%. Chest X-ray is a relatively specific for diagnostic injury with an abdominal stab wound, although low in sensitivity. Abdominal CT is the investigation of choice for assessment of injury to the liver, spleen, but lacks sensitivity for detection of the mesenteric, hollow viscerus, and diaphragmatic injuries. Negative fast scan has a negative predictive value for laparotomy of only 60%. It may miss the free intraperitoneal blood and will not reliably identify injuries to structures such as diaphragm and bowel, which requires operative repair. Okay, so E was the correct answer in this question, which was a fast scan is high negative predictive value for injury requiring laparotomy. Now, so we'll move on to the next question. Uh, just wanted to ask everybody, is my speed okay? If you're not able to understand or you're not able to catch up, you can just unmute and tell. So I bit slow because in it is very difficult to complete so many questions in only 1 hour. If I will be quick, I'll be able to complete maximum of the questions what I can do. Okay, so I'm a bit fast in this. The following are the common lab features of toxic mogacolon except metabolic alkalosis, hypokalemia, raised hematocrit, anemia, leukocytosis with left shift. Okay, okay, anyone wants to answer this question in the chat box? Answer if even if it's wrong. You learn from your mistakes. Okay, metabolic alkalosis. Okay. Okay, anyone else? D. Okay. Let's see what the answer is. Answer is C. C. What is the answer? It's anemia. Anemia is except they have asked. So anemia is not commonly a feature of toxic megacolon. Why? See, enteral losses of potassium and fluid may cause volume depletion. So hypokalemia and metabolic alkalosis, which carries a poor prognosis. Although these patients are often volume depleted, anemia is usual due to the blood loss per rectum with a lowered hematocrit. Okay, leukocytosis is seen as a component of the inflammatory response. Left sheet refers to the fact that in severe inflammation or infection, a greater proportion of immature neutrophils are present in circulation due to excessive cytokine stimulation of the bone marrow. So, except they had asked, and the answer was C in this case. Okay. So next, this is a 33-year-old woman present with right upper quadrant pain and generalized abdominal swelling. She's previously takes no medications other than oral contraceptive. Past medical history is unremarkable. apart from a deep vein thrombosis in pregnancy, hepatomegaly, ascites, peripheral edema is present. Ascitic fluid shows neutrophils 10, serum ascites to albumin, SAG of 1.3, 24-hour urine protein concentration 90. She denies alcohol excess. The most likely diagnosis from the list below is, you have to find the diagnosis. The options are the acute alcoholic hepatitis, Budd-Chiari syndrome, SBP, metastatic disease, or nephrotic syndrome. Yeah. We very one or two very typical hints are given in the question. If you catch that, you will get the answer. It's a very direct question which is given. You'll get such questions in the ED. I think yeah. Most of you have got that correct. It's Budd-Chiari syndrome. What is it? It is caused by the occlusion of the hepatic venous outflow by a variety of conditions, including inherited thrombophilias, use of oral contraceptive pills, pregnancy, chronic inflammatory diseases, and various tumors. It may present acutely with classic triad. What is the triad? Ascites, hepatomegaly, abdominal pain. This is the classic triad which is seen in this. In the latter case, a collateral circulation has time to develop and ascites may be minimal. The Doppler ultrasound is reasonably sensitive and specific screening investigation, but the gold standard for this, hepatic venography. Management of Budd-Chiari syndrome includes the medical treatment of ascites, anticoagulation, reduction of venous pressure, which may require portosystemic shunt. The serum ascites albumin gradient differentiates between the portal hypertensive ascites and other causes and considered more accurate than the older classification of exudates and transudate based ascitic fluid protein concentration. The other options were nephrotic syndrome, but nephrotic syndrome can cause ascites and peripheral, but defined as urine protein excretion of more than 3 gram per day. SBP is likely if a neutrophil count is more than 250 per mm³ is found in ascitic. So other options are ruled out, but Chiari was the most important option which was there. So one thing I just wanted to talk at this point to you is that EDIC 1 exam, mostly it is a test of your knowledge. Okay, they just want to see theoretically whatever knowledge you have, how much deeply you know the subjects. So what I tell my students while preparing for uh, EDIC 1 exam, read topic very deeply. Even a small topic is there, just don't go through. It's not good to read all the topics, but superficially. If you don't have time, leave some topics, but whichever topic you are reading, just go deep into it, because the MCQ can come from the smallest of a single sentence which is there. Okay. On the other hand, the EDIC 2 exam is more of your practical knowledges, nothing about theoretical. In that exam, you need to know, even if you know something about a thing, about a topic, you should know something about every topic. Understanding what I'm trying to say. EDIC 1, you should, if you leave something, you leave it completely, but whichever topic you read it in very deep, because superficial study would not help to answer the MCQs. Whereas in EDIC 2, while giving a Viva, even if you don't know in the depth, you should know something about the, at least you can utter few words, you can tell something about the topic, which would help you pass. Okay. Let's move on the next one. A 60-year-old man with a history of heart failure with reduced ejection fraction, COPD requiring home oxygen, GERD present with dysphagia of solid and liquid foods, which has worsened over the last year. Esophagogastroduodenoscopy is performed, which reveals a normal esophageal mucosa with negative biopsy results. High resolution manometry reveals an integrated relaxation pressure of 20 mm of Hg and distal contractile integrant DCI it's called, it is less than 100. Esophagogram demonstrate a distal esophagogram with poor emptying of barium. Which of the following therapies would be most appropriate for this patient? Nisan fundoplication, botulinum toxin injection, esophageal pneumatic dilatation, or per oral endoscopic myotomy. See, this is a difficult type of question for a critical care people. It's a kind of difficult. You would say it's more of a gastroenterologist question. They would like to do whatever they want. But EDIC, you get few questions which are like of more difficult ones. If you can solve this, it's okay. If you cannot, you should concentrate more on the important critical care topics in which you can score the full marks and not miss anything. Okay. B, someone has answered B again. I think most of you may be doing a guesswork in this. It's quite a difficult one. D, someone has answered. So if you read such questions and it would have come, so it is easy for you. But if you have not read this would be quite difficult. I don't expect anyone to answer this. So answer for this is C. What is C? It's esophageal pneumatic dilatation. Why we see this answer is in this? Because the diagnosis here is achalasia. It's achalasia. It is a primary esophageal disorder with pathological consequences of degeneration of ganglionic cells in the mesenteric plexus of the esophageal body and the lower esophageal sphincter. The degeneration leads to insufficient relaxation of the lower esophageal sphincter, and the esophagography typically reveals esophageal aperistalsis with the proximal dilatation and minimal lower esophageal sphincter opening, resulting bird beak appearance. Could you see the esophagography? They have given the finding that was the clue in the question to for the diagnosis. But the question here was about what is the treatment of it. So just we'll see what answer are there. The at present achalasia is incurable and management consists of palliation of symptoms. In patients who are felt to be good surgical candidates, laparoscopic myotomy with partial fundoplication is an effective strategy for the long-term resolution of symptoms. However, in patients who are high-risk surgical candidates, initial treatment with graded pneumatic dilatation is recommended. Okay, so kind of a theoretical question just to learn and by heart. In critical care, I don't think you'll do these things, but such questions come. That is why I have put such a question. Other options were fundoplication, botulinum toxin, poem. So these are not the correct answer. It was pneumatic dilatation serial was the correct answer in this. Okay, let's move forward. The next question. This is a 65-year-old female with history of smoking, arthritis, osteoarthritis, recovering well from a cosmetic plastic surgery procedure. On post-op day, she has resumed her home medications, including aspirin, and has been prepared for discharge. However, she became hypotensive. Transferred to the ICU, 1 liter of normal saline, BP 90-60, heart rate 118, pale, diaphoric, agitated. Incision is clean and dry. Lab results HB 6.5 from 12. Last check 2 days prior. She has had an episode of hematemesis and BP drops 70/40. Transfusion of PRBC is initiated. Most appropriate next step in the management of this question. Read it carefully. They are asking the most appropriate next step. Okay. Stat CT angio of the abdomen, interventional radiological consultation for possible angioembolization, urgent surgical exploration, upper GI endoscopy, or PRBC transfusion to hemoglobin more than 10 with no further interventions. You can answer in the chat box D, T. Yeah, I think most of you have got this correct. It's very typical upper GI bleed question which comes and which is the most appropriate next step they have asked. This you should keep in mind, then you will get the answer correct. Okay, so the next appropriate was D is the correct answer, that is upper GI endoscopy. So most of things could have been done in this patient, but why upper GI endoscopy is the most important answer, I'll tell you. So this patient with hematemesis becomes hemodynamically unstable because of the upper GI bleed. It is very clear in this. Okay. Smoking, aspiration, NSAIDs, peptic ulcer disease, and in this case, the patient likely has acute bleed from an ulcer. Up to 50% of peptic ulcers are asymptomatic until bleeding occurs, which may present as hematemesis or melena. Upper GI endoscopy is the gold standard for the diagnosis of peptic ulcer disease and the first line therapy for the bleeding ulcers. This should be performed urgently in hemodynamically unstable patient as it allows for both diagnosis and treatment. Okay, so the answer was upper GI endoscopy only because it's not only diagnostic in this case, it will be therapeutic also. So this double advantage makes upper GI endoscopy the best and the most appropriate which is to be done in this patient. Okay. Other options will rule out. CT angiogram of the abdomen may identify source of bleeding. However, it is less sensitive than endoscopy for identifying source of bleeding. And also it does not allow therapeutic intervention. Regarding surgical exploration, it is associated with a higher risk of complications than endoscopic management and so should not be pursued initially. It should be a last resort. If this doesn't help, then you go for surgical exploration. Okay. Angiographic embolization is an alternative to repeat endoscopy or surgical intervention, but does not replace the initial endoscopic management of upper GI bleed and may have a higher risk of rebleeding than surgery. Transfusion of blood products are essential in early management of this patient and hypotension and evidence of bleeding. Although resuscitation goals in upper GI bleed may vary, restrictive strategies are recommended for hemoglobin is associated with higher rates of mortality and rebleeding and therefore not recommended. Okay, no need to give blood transfusion for 10 of hemoglobin. In such cases, it increases the bleeding also. See, in a few of the questions, just wanted to tell you that a few of the answers you may feel that this is not correct, this is correct. They give few of the answers, EDIC people, which are all of them may be correct as per you, but you will have to uh, answer which is the most appropriate out of the following. Okay. So just to tell you, these are the clinical guidelines of upper gastrointestinal and ulcer bleeding. You can find it on net. If you can go through, this would help you. Okay. Next question. I'm going to the next question. It's 11 number question. This is a 55-year-old man with hypertension, anxiety, diabetes mellitus recently adjusted his medication regime and began taking clonidine. He presents now with abdominal pain and nausea. This has been associated with occasional episodes of MSS of gastric contents over the past few weeks. His weight is unchanged. His vital signs are within normal limits. On physical examination, abdomen distended, moderate tenderness in epigastrium, rebound guarding. Electrolytes unremarkable, glucose 350. Upper endoscopy and CT scan showed large amount of gastric contents with no evidence of mechanical obstruction. Okay. In addition to reviewing his medication list, which is the best next step in caring for this patient. Okay. Which is the best next step. First is nasogastric decompression, dietary modification, and optimization of glucose, PPI treatment, percutaneous gastrostomy tube for venting, and surgical consultation for gastrojejunostomy. You can answer in the chat box. See, I don't say all these questions are made by me. I get it from various MCQ books. You must have read this question if you have read few MCQ books. My work in this hour is just to guide you and give you tips how you can read and how you can prepare yourself for the EDIC exam which is upcoming for you. Okay, you can get hundreds, thousands of MCQs everywhere. You can go through each and everything. But my focus in this whole lecture in an hour will be not just teaching you the topics. You can read the topics everywhere. There is so much material available to give you important tips how you can prepare yourself in the EDIC 1 and you can pass. Okay. So what is the answer for this? Always concentrate on the last line of the question. Best next step. I think A, B, B, A, B. Many answers are coming, but if you read this carefully, few of the clues were given in the question. So B is the correct answer. B is dietary modification and optimization of glycemic control. Why? This is a case of gastroparesis or delayed gastric emptying. Is the motility disorder in which food remains in the stomach for a prolonged period. It presents with postprandial fullness, nausea, vomiting, pain, bloating. It may be due to a variety of factors. Medications prolonging gastric emptying are alpha 2 adrenergic agonists. Could you see in the question they have given in the first sentence itself? He began taking clonidine. It's an alpha 2 adrenergic agonists which is causing gastroparesis in this patient. The other medications are narcotics, CCBs, TCAs, diabetes medications. Diabetes mellitus is also a risk factor for gastroparesis. First line therapy for gastroparesis is dietary modification and optimization of the glucose control. Large meals and foods high in fat or fiber should be avoided. With this dietary modification and optimization only, most of the gastroparesis patients respond. So no need of going for other things. We'll rule out other of the options. In this patient, there is no mechanical obstruction and there is no current complaint of emesis, making nasogastric decompression unnecessary. So nasogastric tube is not required in this case. Similarly, there is no mention of ulcerative disease on this endoscopy and therefore no indication of PPIs. Gastrostomy tube is very rarely indicated in gastroparesis and certainly not in this patient with recent onset of mild symptoms who has not yet tried lifestyle and medical management. Gastrojejunostomy can be used to bypass a mechanical gastric outlet obstruction, but will not improve the motility of the stomach. Okay. No worries, because few of you have got that wrong. Don't worry, you just started reading for the EDIC one. As you progress, the more and more MCQs you read, you get used to it, and a pattern is created in your mind how to answer these MCQs. So one thing I just wanted to discuss at this point for my students, that there are different ways people start studying for this EDIC exam. Few of the people, what they do is they go on reading all the topics and then they try to solve the MCQs. While the second type of reading or preparing for the exam is try to read the MCQ and the topic, whatever the topic is there in the MCQ, and then you retrogradely try to read the topics. I think there is a different person can do it differently, but retrograde studies are found to be better, which will help you solve the MCQs better. Because the thing is, the more and the more MCQs you go on reading, the practice you get, and there are more chances you will solve them properly. Just reading the texts and the theoretical things, it would be helpful, it will clear your topics, but MCQ reading is very very important to just pass in this EDIC1 exam, what I would suggest. Okay, rest it's individual strategy, you can do however you want. Okay, now next question. This is 34-year-old man with a Crohn's disease presenting with foul smelling drainage from abdominal wall. He has experienced malaise, poor oral intake over the preceding 3 weeks and has been worsening abdominal pain for 5 days. The last 3 days, he noticed swelling of the abdominal wall superior to the umbilicus in an area that has begun to drain foul smelling greenish discharge. The area has become erythematous, tender, drainage has increased volume over the last 24 hours and started to develop fever, chills, dark urine. On arrival to the ICU, 102 degree Fahrenheit, 110 heart rate, BP 95, respiratory rate 18, saturation 98%. CT shows oral contrast extravasation from the small bowel that exists at this stage of drainage, but no drainable fluid collection in the abdominal wall. What is the most appropriate management at this time? Okay, so most appropriate management for this patient: take the patient to the OR urgently for exploratory laparotomy, start broad spectrum antibiotics, monitor fluids and electrolyte status closely, and nutritional support, perform incision and drainage at the bedside, percutaneous jejunostomy tube placement to initiate tube feeding, or consult gastroenterology for endoscopy. If you know what is happening in this patient, the diagnosis, you could easily tell the B. Anyone else? B. Yeah, I think most of you have got this correctly. If you don't, even if you don't know, don't worry. With practice reading such questions, you will be able to solve these questions. Okay, so answer for this is B, correct. It is a case of enterocutaneous fistula, and the most appropriate management at this time is to just to start the antibiotics, fluids, electrolytes, and nutritional support, and it will get resolved with this itself. It's a very big explanation given for it. It would be difficult for me. I'll miss some MCQs. You can read enterocutaneous fistula. Everywhere you'll get this topic. Just I want to rule out the other options last, because one of the option was to take the patient to the OT urgently. Many of you thought this is the correct answer, but majority of enterocutaneous fistula heals on their own, and if needed, surgery can be performed in a delayed manner. It's not the first option and the most appropriate one at this stage. Just treat. If not, then surgery would have been an option. Incision and drainage is not needed as there is no drainable fluid collection in the abdominal wall. Percutaneous jejunostomy too would not be appropriate before fully defining the anatomy of fistula. And neither upper GI endoscopy nor colonoscopy would be beneficial, as we suspect the fistula to be located in the small bowel. And there are more effective methods of localization than better depicted in the small bowel. So this was also ruled out. Okay, let's move on to the next question. So again, very long question. Just to waste your time, we should be very quick in reading this. Okay, this is a 38-year-old male presenting with a bout of hematemesis, 400 ml bright red blood in the ER, tachycardic, hypotensive, large bore IV cannula obtained, received 2 units of PRBCs, intubated for airway protection, admitted to the ICU. On chart review, he is found to have significant alcohol abuse history and several admissions for alcoholic pancreatitis, but his LFT and coagulation parameters are normal. MRI, abdomen, and liver biopsy, no evidence of cirrhosis. Patient started on IV PPI, IV octreotide. Beside USG, showed no signs of ascites. Subsequently undergoes esophageal gastroduodenoscopy that demonstrates oozing gastric varices that were sclerosed with cyanoacrylate, and EUS shows the thrombosis of splenic vein and calcification of the pancreas. He remains hemodynamically stable, extubated. 6 hours later, he has another large volume hematemesis, becomes hypotensive. He receives additional 3 units. It stabilizes his blood pressure. What is the next best step? What you'll do for this bleeding now? It is a second time bleeding. The options are TIPS, nadolol, continue massive transfusion, splenectomy, or catheter directed TPA to splenic vein. Another question on upper GI bleed, very favorite topic of EDIC examiners. Upper GI bleed, HRS, C. difficile infections. This in gastroenterology, these are very common and important topics which are of favorite of the EDIC. D, someone has answered. Someone has answered A. Anyone else want to answer? Can take part. Okay, E. Okay. The correct answer, yeah, someone again wants to answer this. A, tips you want to do in this case, which is bleeding again quite massively. So the correct answer, I think, is D. D is splenectomy. Why? We'll see why this answer is correct. The patient has a history of significant chronic pancreatitis, which carries 8% risk of splenic vein thrombosis. Splenic vein thrombosis can lead to left-sided portal hypertension. Majority of the patients with splenic vein thrombosis have no gastrointestinal bleeding, and splenectomy is no longer considered as the ideal treatment in asymptomatic patients. Okay, but what is happening here is patients have typically normal liver functions and have no signs of cirrhosis. Management includes EGD for the diagnosis and management, banding, sclerotherapy, obliteration. However, in acutely bleeding patients who have failed the endoscopic management, splenectomy is the ideal choice to control the gastric variceal bleedings. Okay, so if would have been a first bleeding, OGD would have been a good option, but here the patient is having acute bleeding which has failed its management. So you have to go for splenectomy, which is an ideal choice to control the bleeding in this patient. Okay. Nadolol is useful to decrease the portal pressure, and it is for the chronic management. Okay. Tips will not decrease the portal pressure within the splenic vein as the obstruction is proximal to the portal vein. Okay. The patient is now stabilized after receiving 2 units of PRBC, thus ongoing massive transfusion protocol would not be useful. TPA is currently not indicated for portal vein thrombosis. Okay. So splenectomy was the best choice in this recurrent bleeding in which the first endoscopy has failed. Okay. Next, moving on. This is a 55-year-old female admitted to the surgical intensive care unit and severe abdominal pain, nausea, vomiting, diarrhea for the last 3 days. Heart rate 122, BP 100 by 50, temperature 102, abdomen is diffusely tender and voluntary guarding. Leukocytosis 18,000 cells, hypokalemia. Thorough medical examination is significant for recent diagnosis of ulcerative colitis treated with sulfasalazine and recent UTI of which she completed 7-day course of ciproflox. CT abdomen and pelvis is performed which demonstrate significantly dilated colon up to 6 cm in diameter and diffuse colonic wall thickening with patent vasculature. What additional testing is required before full medical management can be initiated? Okay. What additional test you will do in this patient? You will do CT angiography of mesenteric vessels, colonoscopy, C-difficile stool tests, serum CMV test, or barium enema. This is a very typical uh, history which we get leading to a important diagnosis. And if you have got the clues in the question, you can answer it correctly. C. Yeah, yeah. I think most of you got this correct. It's C. difficile stool test, which is to be done in this case because the CT findings you see it's a dilated loop 6 cm with diffuse colonic wall thickening and patent vasculature, highly suggestive of toxic megacolon. It can be a case of toxic megacolon, which is a complication of it. So this patient has the findings concerning of toxic megacolon. It has the following criterias: radiological evidence of colonic distension plus any three of the following: fever, heart rate, tachycardia, neutrophilic leukocytosis, plus at least one of the following: dehydration, altered sensorium, electrolyte disturbances, and hypotension. Okay, you can go and read the complete topic toxic megacolon. Any MCQ can come on this. I'll not go into the detail of this complete. You'll get in text much of the things. Okay, we'll quickly move forward. Only 14 questions are completed, and I think we have much time left. I'll quickly try to cover a few more questions. Okay. So, this is a 53-year-old male with past medical history significant with alcoholic cirrhosis, complicated with esophageal varices, present in the ICU with hypoxia. He has noticed dyspnea on exertion that has been worsening over the last several months and complaints of platypnea. Okay, breath sounds are clear, chest radiograph is normal, contrast CT is negative for pulmonary embolism. Which of the following is the most definitive treatment option for this disease? Very important clue in one word given in this question. If you get the diagnosis, you can tell the answer. So definitive treatment option, it's broad spectrum antibiotics, therapeutic paracentesis, nebulized bronchodilators, liver transplantation, or bronchoscopy. The clue to the answer is only one word in this question. Good. Someone has answered D. Anyone wants to attempt more? Okay, okay. Let's see. Let's see what the answer is. Answer is correct. D. Someone has answered. The platypnea, what was given, it is a very important clue which see, the history of dyspnea on exertion over a period of months in this patient with cirrhosis with portal hypertension makes hepatopulmonary syndrome a possible diagnosis. Platypnea, it affects 66% of the patients with hepatopulmonary syndrome. Okay. Hepatopulmonary syndrome is progressive and the only definitive treatment is liver transplantation. So it was a hepatopulmonary syndrome, which clue was given was platypnea, and the treatment for it is liver transplantation. Other options, I don't think it's much important. It was a very clear-cut question. So next, this is a 63-year-old man is in the ICU waiting for liver transplantation. He has become increasingly agitated and combative. His white cell counts are 8,200, sodium 132, potassium 3.1, creatinine 0.9. Blood urea nitrogen is 15. CT reveals mild cerebral edema with no bleed and focal abnormalities. He is receiving lactulose and high bowel movements 3 times daily. Which of the following is most likely to improve his agitation? What you'll give for agitation? Midazolam, suppository, soft restraints, antibiotics, or potassium? Can answer in the chat box. Very typical question. It's hepatic encephalopathy, very clear. What is the most likely to help in that? Potassium repletion. Okay. Most of you got this answer correct. Yeah, one more someone has to answer. B. Okay. Let's see what the correct answer is. The correct answer in this is E. E. What is E? Potassium replenishment. Why potassium replenishment is important in a patient of hepatic encephalopathy? See, this is a patient of hepatic encephalopathy. 30 to 40% patient with cirrhosis will at some point have hepatic encephalopathy. It can be precipitated by a number of factors, including infection, constipation, GI bleed, electrolyte disorders. Identifying and treating the precipitating factors is an important component of treatment. Hypokalemia increases the production of ammonia within the kidney through an effect mediated by changes in the pH within the renal tubular cells. So hypokalemia is very detrimental. It increases hepatic encephalopathy. So hypokalemia should be corrected in a patient of hepatic encephalopathy. That was the answer. Other options, midazolam will not give soft restraints. It will not improve the agitation. Broad spectrum antibiotics, if there is a infection, we can give it. And lactulose is one of the most oftenly used treatment, and this patient is already stooling regularly, so the addition of suppository is unlikely to be helpful. Okay, move on to the next question. Okay, long question. So now this is a 35-year-old woman evaluated in ER for fever, severe epigastric pain, nausea that has worsened during the course of 12 hours. She denies any medical history. Father has a history of gallstones. The vitals are the temperature is 38.4, heart rate 115, BP 90/60, respiratory rate 19, oxygen saturation 93% on 2 liters. Okay. After blood is drawn in laboratory, she is given 4 liters of RL over 4 hours. She is given IV hydromorphone 1 milligram for pain, vancomycin 1 gram, cefepime 2 gram for fever. Abdominal ultrasound is equivocal for gallbladder wall thickening, but shows pericholecystatic fluid and a dilated pancreatic duct. The pancreas appears inflamed, but no necrosis or cyst is noted. Critical care services is consulted for severe pancreatitis. Vital signs after 4 liters of crystalloids are temperature is 38.9, heart rate 109, BP 110/75, respiratory rate 22, saturation is still 91% on 2 liters. Lab shows burn of 45, creat 1, AST 235, ALT 129, amylase 2023. Bilirubin 2.9, lipase 4320, WBC 14,000, HB 15.5, hematocrit 47%, platelet 4,50,000, lactate 1. Which of the following principles applies to the patient's management? So one thing I would just want to discuss at this point with you all are there are a few different types of strategies people use in solving the MCQs. Like in very large MCQ, what happens? You concentrate so much, you try to note down each and every small findings which are given in the question, and at the last you forget whatever you have noted down. One thing few of the people solve the question is in a way is in very large questions, you can read the last line first. So in this whole question, there are many values and things given. If you read the last line, which of the following principles applies to patient's management? And then you go and start reading the question, so you know what exactly you are searching for in the whole of this story which is going on in this. And it is quite easier to grasp the things and answer the question. I'm not saying everybody should do this, but in big questions you can apply this strategy. It would help you get the answer quickly, because the in EDIC exams, big questions, very big questions, many of the findings and things are given just to waste your time, and you're not able to complete the exam in 3 hours. You leave some of the easy questions which you could have answered if you would have time. Okay, so in this question they have answered, the question is to which principles applies to this patient's management. The options here, they have given immediate CT with contrast to provide most prognostic information. Empiric antibiotics should be continued because this will decrease the risk of death. Initially, she should be given bowel rest because of enteral feeding may worsen the prognosis. CT radiography may be helpful in determining her disease predicted mortality at 30 days, and further IV fluids will decrease her risk of death. Like such a big question, very simple diagnosis. You know what the diagnosis is, and they are asking about the patient's management. I think see someone has answered. Okay, any other one wants to answer this? See, someone has answered. Okay. Let's see what exactly is the answer. It is a severe pancreatitis, and E someone has answered. Okay. It's a clear cut pancreatitis. No need to read so much of the things in this. Directly the options. The answer here. Okay. And anyone else want to answer? E. Most of you answered in this. But unfortunately, it is not the correct answer. The correct answer here is D. What is D? A chest radiograph may be helpful in determining her disease predicted mortality at 30 days. Why? Why this is the answer? If you have read acute pancreatitis, you would know there are various scoring systems in it, and the most important one, which is commonly used at bedside, it's the bicep scoring system. Let's see why the answer is D. The most widely used scoring system is Apache 2, but it is cumbersome. The bicep scoring system is validated and easier to calculate. The bicep score consists of blood urea, nitrogen, impaired mental status, SIRS response, and pleural effusion. Score of 3 or more shows a significant increase in mortality in patient with acute pancreatitis. The presence of pleural effusion in this patient takes the score from 2 to 3, which increases her 30-day mortality. A chest radiograph also can show the presence of pneumonia and ARDS. It completes the clinical picture. So the question was in this acute pancreatitis was the 30-day predicted mortality would be very easy if you can do the bicep scoring. For the bicep scoring, you need to know whether there is a pleural effusion or not. To know if there is a pleural effusion, you need to do a chest x-ray of the patient, and that will tell you whether the pleural effusion is present or not, and that will complete your bicep scoring, and you should know what would be the predicted mortality of this patient. So very important bicep score bedside. With this few of the investigations, you can predict the mortality, and that was the correct answer. Okay. uh, i think I think already 1 hour 5 minutes we have exceeded. I think we should stop over here. I could complete almost 17 questions in this, and more questions if you want to read. There are many books. You can just go and read. You'll get MCQs everywhere. In this in this lecture, I wanted just to give you some tips so that you would be able to prepare yourself for the exams. MCQs, teaching like this MCQs would not help. You have lots of books and places where you can read the MCQ. I tried to give as much of tips to you as possible. If you have any doubts in any questions, if you have any more things you want to ask, you can just message me or message Furs Academy. They would be able to communicate to me, and I would be happy to answer any questions from you. Last thing what I want to tell you all about is about the books. Read as many MCQs as you can from many places you get. Most important, I would recommend is the Bennington, both the editions you read first. There's a very good book called of Society of Critical Care Medicine USA SCCM book. The latest edition had come around year and a half back. It is a very good, very few MCQs, but they're excellent MCQs. Third thing I would like to say regarding the MCQs is you must have registered in the EDIC. So when you go to the EDIC site, you go into the academy, there are many ACE modules, ACE modules. Previously they were called packed modules. Now they have given ACE modules. Around 50 ACE modules are given on the EDIC site. At the end of each module, there are 5 to 6 questions given in it. These questions are very, very important and given from the EDIC people itself. Few of the questions come in the exam as it is. It's not always 100%, but these MCQs are very, very important. I would highly recommend you to go to the EDIC site and open the ACE modules. You'll not be able to read each module because there are very vast modules. Few of the important ACE module topics you can complete, and at the end of each module they have given very few questions. In some modules there are 2 to 3 questions. In big modules there are around 8 to 10 questions, and when you submit it, they will give you a score also, and they will give you explanation of the questions also. Those MCQs are very, very important, but I don't think only that would help. The other books what I told, Bennington both editions, SCCM book, there are many more books, 1,000 MCQs, and you'll get hundreds of books in the market. But these are the basic. This much you should complete before applying for the before going for the EDIC 1 exam. That is what I want to suggest. Okay, I think 1 hour class, 1 hour 15 minutes. This is more than enough. You will not understand anything after that. Everything goes above head. So I would not continue. I'll end this class. If any doubts, you can just message. I would be happy to answer your doubts. If anyone wants, they can unmute and talk. If anyone wants any explanation of anything or any doubts here itself. So someone is asking for the number. Don't need to give the number. You can just message Furs Academy. I would be happy to answer. Regarding the books, I have already told you the Bennington books are there, both the editions, SCCM book and the ACE modules, what I recommend. Rest, it's up to you. You can read as many books. There are many books available in the market. You can read as much time you get. But only suggestion I told you previously is, don't just go and just ratta all the text and all the theory. It would not help in adequate. The more MCQs you read, the more practice you get solving the MCQs. Okay, I'll end this class over here. Thank you everyone for joining the class.